please put in your questions via the chat, and me and Ahmed will moderate those questions at the end with Prof. Colombo. So it gives me great pleasure in having a very good personal friend, and I really thank him for everything all the successes I've had in my career, because it's thanks to his leadership and mentorship and training. So it just seemed fit to have you, Antonio, present what I think is one of the more fun lectures I've heard you give. Thanks, Antonio.
Thank you very much. Thank you, Azim. And the best joy we can have in our life is to live positive, not memory, but positive things in our life for other people to continue our ideas. So let's go to these, I call these my messages. There are several messages. I have nothing to disclose regarding this presentation. I have 2 or 3 introductory slides, then we go to practical. We are in a difficult time. Always we are in a difficult time, but this is particular. We need the strength, we need intelligence, we need humanity, we need also humility, and we need to be patient, but not to just to be lazy. We have to have a constructive patience. And this should always be not only in difficult time, in every time. But we should be able to take a constructive lesson from any situation, and the more adverse the situation, the more constructive should be the lesson. So sometimes Mother Nature blesses us with tough situations in order to be positive. I have 3 or 4 historical slides, but I think for young people, and I'm surprised how many young interventionists don't know Jeff Hartley. Jeff Hartley was a key figure in angioplasty. In my idea, as key as Granzig. He is the father of complex angioplasty and primary angioplasty for acute myocardial infarction. These are very important steps that Jeff put in our field. Other 2 key people to know is Ulrich Siegbert and Gary Rubin. These are the real father, in my opinion, of coronary stenting. Stenting at that time was not mainly used to prevent restenosis, but was used to treat sudden coronary occlusion. This is an occlusion of the LAD, which was successfully managed by stent implantation. So stenting made angioplasty safer and gave us the possibility to do procedure without surgical standby. If we did not have stents, we would have dependent all the time to surgical standby. Even angioplasty will not survive. Another 3 slides, and then we go to something more actual. We started this idea of coronary stenting with dual antiplatelet therapy and IVUS guidance in '95. And these are not a randomized study. I really never really believed much in randomized studies. We did a case series, one after the other. And these are our results. In '95, we had a very low thrombosis, was 0.9 with teclopidine and aspirin. Why I show these 2 slides? To show you how funny is academic field. We had to wait 3 years, 98, before coming to an FDA-accepted trial. And some poor patient had to undergo stenting only with aspirin, having a thrombosis rate of 3.6, when we were totally aware that only aspirin was no good, and aspirin with warfarin was mediocre. So it's amazing how sometimes cruel is academic medicine or real proof of your assumptions. But I'm puzzled that 94%, 96% of the patient who took only aspirin did not experience stent thrombosis. So this is funny, but when we think about monotherapy, think that even in the 98, only 4% of the patient did not get thrombosis with a simple aspirin. Now let's go to one of my interesting cases, because it's a complication, but I want to start with this because I want to introduce the idea of thinking before acting. Unfortunately, interventionists act and maybe think later on. These elderly who undergoes elective angiography, I don't really, with a soft indication, history of unstable angina, because she had to undergo AAA treatment. And this is the first injection in the left corner. Patient is totally stable. It's amazing what you see and the feeling that the operator had when he saw this first angiogram. He took another view, and this is a second view. And what is more amazing, that the patient is totally stable, no ECG changes. The right corner is normal and there are no collateral to the left. The mistake the operator did, he acted with his lower brain. He did not use his cortex. So when you see an artery closed, the first reaction is to open the artery and not to understand what's going on. And that was the operator did. He went into the dissection, extended the dissection, placed a balloon, and to make the story more wrong, he even placed a stent, and then the patient became unstable. I don't want to make you lose much time, but if you go back to the very previous slides, you see that in the late frames, there is the LED that comes about. Means that there is a left main dissection induced by the catheter, but there is another lumen underneath. And if the operator would have realized this, that would explain the absence of ECG changes, he would have placed a short stent in the left main, going into the right channel, and the case was closed. Unfortunately, he made a series of mistakes. Finally, patient recovered, but I think the value of this slide is that before you act, you have to think and make a diagnosis before establishing therapy. So when you encounter a question, sometimes it's not always like this, because sometimes you find the answer before coming with a possible solution. And life is sometimes in this way. In this case, we did not. But in other cases, we find the solution. So sometimes the answer precedes the solution. And we should not be upset. We have to be a little bit open-minded and accept that sometimes you find the solution even before finding the answer. That's life is sometimes one way on the right and the other way on the left. Let's go to some slides dealing with common complications that are still happening nowadays. Occluded vessels are rare, but what I think is still a contemporary complication is perforations. For perforation or rupture, we should use cover stent, coil and delivery catheter in microsphere. All these items should be readily available in the cath lab, because the perforations and rupture are still happening and are sometimes very difficult to be corrected even with surgery. The other complication important to deal with is slow flow. Distal embolization is slow flow versus dissection. Do not make the mistake to come to the diagnosis of dissection when you're dealing with slow flow. The worst is to place an additional stent when slow flow is a problem. And this is a repeated mistake that I see every 3 or 4 months. This is a typical example of slow flow or no flow. And there is a balloon distal to a series of stents, and the way you make the confirming diagnosis is to inject, but distally. In this case, we broke the balloon and we utilized the balloon lumen to inject, and the dye, instead of going down, goes up. If the dye goes up, when you inject distally, you are dealing with no reflow. If you have a dissection, if you inject distal to the dissection, the dye goes down, does not come up. So this is a very important way to make the diagnosis. And then you deal with the slow flow nitride, adenosine, or whatever, but do not place any additional stent. If you plan to place a stent, do not leave the lesion not stenting, because it's difficult to deliver the stent. If at the end you cannot place a stent where you decided to do so, perform IVUS and FFR to justify leaving a non-stented lesion. Rarely now we cannot place a stent, but if it happens that you cannot place a stent in a situation where you desire to place a stent, make the final evaluation in order to justify why you change your mind. In reality, you did not change your mind. You could not fulfill with your plan, but come out with a reasonable way why you did not fulfill your plan.
Antonio, I'm going to quickly interrupt you for a question because I know you like being interrupted during your presentations. So when you have no reflow, what is your algorithm? I mean, what drugs do you usually use to treat no reflow? And is it different if it's in the case of a STEMI or in a case like the one you showed, which was not a STEMI case?
No, it's the same. If I have no reflow, the first things I go distally with the selective catheter. If I have the twin rail or any selective catheter leaving the wire, go very distal, inject nitride and maybe a little drops of adrenaline or noradrenaline to keep the blood pressure up. Some people use adrenaline also for no reflow. And I try to correct by repeated injection of nitride, very distal, but very distal, not at the coronary ostia, but where you have no reflow. And then if you need support, if you have the luxury to have balloon pump, impeller would be the best if it's really big time no flow and the patient is hypotensive. But the key is to give adrenaline, noradrenaline, and nitride or verapamil, but I prefer nitride as my first choice.
Thanks.
Hemodynamic support. It is better to use the support when not absolutely needed than being sorry for not having used it. So the number needed to treat does not need to be 1. So, okay, your colleague blame you could have done without support. It's okay, but in medicine, we are also used to have a number needed to treat of 3. Balloon pump, I believe, is still valuable. I still believe in balloon pump, despite so many trials highlighting the value of impeller. No question, impeller is more effective, but in some places they don't have impeller. They don't have the luxury to use it at libitum. So balloon pump, I think, is still okay, especially if it's placed not too late. FFR and IFR are numbers. This is my favorite slides. Nothing more. So do not take these numbers as dichotomous. A number is not a dichotomous. It is a continuous. A dichotomous event is life and death, pregnancy or no pregnancy. So, I mean, FFR of 91 is better than an FFR of 81. This doesn't mean that you have to make the FFR of 81 91, but if you have an 81 FFR in the context of a clinical situation which suggests ischemia or exercise ischemia, you can convert an FFI of 81 to 79 with some diligence. Anatomical and clinical context are essential. Minimize mistakes. I don't know why I have this slide. Of course, you have to minimize mistakes, but sometimes even if you make a series of mistakes, nothing happens, and sometimes you have a good result. This does not mean that you did right. The final result is not always the answer to the decision process that make you go to that result. Look at this case, a tight stenosis of the osteomos, the circumflex left main, elective. There is a balloon pump because the operator felt a little bit insecure. Try to cross in the circumflex, no way, use about 10 different wires, could not. So then he started doing something wrong. He did these are some other choices, but what he did balloon of the left main towards the LAD with the hope to make some plaque shift. When you have such a tight stenosis, it's very difficult to have plaque shift. As a matter of fact, the circumflex did not occlude. I think God was protecting the operator. Then he used the cutting balloon. Then finally used rotablator, but maybe it was too late, no improvement. And he was lucky because at the end he went with the Gaia 2, made a passage and re-entered very easily, proximally. So this means that even if the final success is good, like in this case, the series of events that occurred were wrong. So you have to be critical of yourself and not necessarily evaluate the final result, but evaluate the decision process that you followed. And if the decision process was wrong, don't be afraid to be upset even if the final result was okay, because sometimes luck is not always on your side. We keep on reading the DES trials are inferior to CABG regarding revascularization, and no way, this is a reality. ST elevation MI, acute coronary syndrome, made small improvement, but they made some improvement. Support devices are very important, but in elective patients, we really did not make tremendous improvement. At least we did, but still inferior to bypass. This is an IVUS image of a good angiographic result, but with a poor IVUS result. You see, lumen is still very small, very asymmetric. They use a Shockwave, still no improvement. Second Shockwave and high pressure balloon, still insufficient result. Then they used the OPN, very high pressure balloon at 37 atmosphere, and they succeeded with a good result, 6 square millimeter, 5.98. What does it mean? It means that Shockwave was effective, OPN was effective. You need to understand sometimes that you need multiple devices. I know that it's very difficult to do a randomized trial with multiple devices, but accept the idea that in some situations the answer is not 1. The answer is 1 + 1 and maybe even +1 again. So it's multiple devices are necessary to achieve an optimal result. So don't be too focused on a clean study, which is important if you do a randomized study, but less important if you are doing everyday activity. Learn where stent performs suboptimally. Sometimes in acute MI, stents are not ideal. If you have a lot of thrombus, maybe stent is not a good idea. Don't forget that in the early trial, 98, the first PAMI study, in the stent group, they had 2 deaths, and these 2 deaths were slow flow, and some dissection left that led to stent occlusion. So I'm not saying that you should not use stent in acute MI, but be selective in some situations where stenting may not be the choice. And in another situation where stenting is not ideal is the osteomosis circumflex. We have a lot of case series. We don't have a nice, well-organized paper published, but this lesion at the osteomosis circumflex is problematic with stenting. We're now collecting a series of cases with cutting balloon and drug-coated balloons with sirolimus or paclitaxel. This is one example. Osteomosis circumflex pre-dilated with cutting balloon at high pressure, reasonable result. A drug-coated balloon, final result, not stent-like, but good result, and we are now collecting cases to publish. So this is an area where maybe stenting should be avoided. I say maybe because we need data and we need follow-up. But this case illustrates this point. We like to avoid, and we need to avoid this. This is a patient with a stable angina, with a long-standing occluded mid-LAD due to full metal jacket. There is nothing you can do. You cannot even do bypass. These cases are rare, but if these cases is you, your brother, your sister is a problem. And we have to avoid these situations. Look at this reconstructed LAD, which ended up with a total occluded, and there's no way, even if you reopen this in 3 or 4 months, it will reocclude. They treated the circumflex again. This guy is a lover of long stents, placed a super long stent on the circumflex with a good result, of course, but who knows. When you have diffuse disease, we are trying to collect data to show the value of focal stenting, like in this LAD, and drug-coated balloon for the distal vessel. We have no good data, but we are collecting, and we hope in 1 year we can give some follow-up. How do we decide when we accept the result and we do not stent? We use a baseline PA-PD, the baseline pressure gradient. In this case, the baseline pressure gradient was 64. We stented proximally with the medium length stent, and then we did the balloon. Result is not shining, but in all the distal segments, they are longer drug-coated balloon, and the PA-PD is 91. I'm sure if you do FFR, you may get 78, 79, but it's okay. When you have a PA-PD 91, means that you will not have an occlusion, and you can leave this LAD without a full metal jacket. So I think this is not a stent-like result, but it's an acceptable result. So I believe this is something that you can learn and practice, not always, but especially for the LAD, I believe is something to keep in mind. So to finish, I would like to say that guidelines are important. Nevertheless, we shouldn't be guided by the patient in front of us and by us. And by us, I mean what we can do and what we are able to do. So accept that we have many problems not solved. The stent is not the solution for everything, and the real solution is up to you. New generation interventionists need to provide solutions. And believe, we have many answers, many questions without an answer. Thank you for your attention.
Excellent. Thank you so much, Antonio, for sharing this with us. I'm going to ask the fellows to, Ahmed, who's one of our interventional fellows, to join us and allow them to ask some questions. I'll also put some questions from the chat room if anybody has questions for you. Ahmed?
Thank you, Dr. Latif. Thank you, Professor Colombo, for this great presentation. It's really a great opportunity for all the fellows here. One of the questions that I was thinking about, like all these points that you mentioned are really great, especially about trying to find the answer before the solution. But also like for a newly graduated fellow where like you have a lot of experience during the training, but then, not the seasoning of years of practice by yourself. How do you remember you approach that when you finished your training and when you had your first hard problem to solve, say like your first STEMI, if you remember? Do you remember like how you approach it as a newly graduated fellow?
But you approach you have to, the first cases you do, you have to be successful. It's very important because it really, unfortunately, life is made of the first initial way you present to people and to your peers. So try to be successful at the very beginning. You can make some problems later on, but do not start with the wrong foot and to have problems at the beginning. And if you have some problems, stop and do not justify yourself. Find a solution, share with other people your problems, but do not come out with funny justifications. Admit what you did wrong, maybe you did not know, but take a humility action and try to share your problems.
Thank you.
Do not justify. I hate justifications.
Yeah, I have some other questions from other fellows. Miguel is actually asking about your opinion about using IFR pullback to guide spot stenting in complex diffuse coronary disease. Do you use that routinely?
I don't use that routinely. I use a lot baseline PAPD, and that gives me a general idea. And I use IFR sometimes after. If I see that I cannot improve the distal pressure gradient, I know that I have some poor result. So I use both, but I think IFR is very nice to use. And anything FFR, IFR, contrast is fine. I think you cannot leave dissections without doing some kind of measurement. Do not rely on angio unless it's really a minor dissection. But any dissection that is visible should be stented or left alone with a supporting test, IVUS, OCT, or FFR.
Thank you. One more question on the physiologic assessment. Michael is wondering about your experience with the RFR, DFR. Sometimes here we use RFR or DFR, and then we have seen mixed results, especially when we kind of have a borderline result and we do FFR after that. What's your comment on that?
I think a borderline FFR, I take a clinical decision, vessel, location, size of the vessel, and symptoms of the patient. As I said, if the FFR is 81 or 82 or even 83, could be positive or could be negative. It depends. So if he's 90, I don't really care to go to more detailed evaluation. I can maybe it becomes 88 or 87, but I know that he's okay. So I think I don't go to additional testing to make a borderline FFR positive or negative. I use clinical and angiographic decision to make my final procedural decision.
Yeah. Antonio, the question was also related to all these new resting indices. Now we started just with FFR, then there was IFR, and now we have all these other indices. Every company now has a resting indice. Plus, there's also now angio-guided FFR. Have you found those useful in your practice, or do you just still use traditional FFR or IFR?
I don't like too much these new. It's okay, but the more sophisticated is your index, to me, the more is the variability. So I like standard FFR, IFR, and contrast. I use a lot contrast for clinical because, if I have a contrast of 90, finish. No, I mean, why are you wasting adenosine? Unless if you're doing a study. If you're doing a formal study, is okay. But in clinical practice, contrast is a very simple way to evaluate FFR. But to answer your question, I'm not so fan, especially angio FFR. I think, angiography depends where the catheter, how coaxial is your catheter, how good is your injection. I think there are so many variables.
Go ahead, Ahmed. While Ahmed's getting ready for the next question, Antonio, in the US, one of the discussions that still comes up a lot is radial versus femoral. As you know, the radial use in the US is not very high. What's your own personal experience? Do you use radial, femoral? If you could just share with the fellows.
I use a lot of radials, and I use a lot of left radial. I think left radial is easier. It's a little bit more clumsy for the operator, but when you get used, it's okay, and the seating of the catheter is usually better. If it's a complex case, I still believe femoral is fine, unless you're a real radial expert. But if you have any doubt, you can use femoral. Learn how to use good femorals. I prefer radial, but I do not assume femoral is a mistake. You have to learn how to use good femoral puncture and to do good closure of your femoral puncture. That's it.
Right. And then there's another question I wanted to ask you, Antonio. One of the things, I always see, and it's something we discussed a lot and you taught a lot, I still see a lot of issues with support and as in guide catheter support, and fellows having challenges with guide catheter support, using guideliners very early when they're having a challenge, getting a balloon down. And maybe just also if you could speak to what your approach to that is, and also the difference between sort of whether it's actually an issue with support or the lesion, or whether it's friction when you're trying to get a balloon or stent down.
But first of all, you have to really learn how to use guiding catheter. And you really do not need many guiding catheters. You need right, standard, XB, Amplatz, and that's it. These are three shapes in mammary. 4 shapes of guiding catheter in your cath lab. Nothing wrong with the guideliner, But I think if you use guideliner a lot, it means that you are not able to do angioplasty, because you have to learn. We did a very complex angioplasty for 20 years without a guideliner. And I tell you, big stents. Friction, metal has a friction on calcium. And I think you understand if it's friction by comparing how is a inflated balloon, a used balloon going down, even a non-compliant, versus a stent. If you see that the balloon goes down easily and the stent does not, maybe that friction. And if it's really friction, it's very difficult to correct friction with better support. Sometimes you can, but if you know that it's friction, then don't waste time, go to the guideliner. But sometimes it's really impossible to correct friction, even with the best support. So I think these should be kept in mind.
Great. Go ahead, Ahmed.
A couple of questions on the ostial circ stenting. So the question is, other than the severe angulation, what would make an ostial circ stenting kind of bad strategy? And if we are better with provisional because of that, other than two-stent strategy, when you have also ostial circ involved, when you're approaching distal left main bifurcation?
The ostial circ is problematic. I don't understand why, because even with good angulations, we had aggressive restenosis. I think is a movement with a heart contraction that has something to do. But I tell you, I still have to see a well-done series where the angiographic restenosis as the ostium of the circumflex is less than 25%. I think if you do a good angiographic follow-up of stents implanted as the ostium of the circumflex, at 1 year, your restenosis is high. I don't claim that drug-coated balloons are better. I claim that we need to investigate these alternative solutions by measuring pressure gradient at the end and leaving some ostial stenosis unstented if the final gradient is low. We have to collect maybe 50 cases, do angiographic follow-up, and then we can get the answer.
Pending those results, what is your personal approach? Do you tend, for example, to do IFR or do IVUS, and then based on some cutoff, you tend to leave the ostial circ unstented?
I tend to stent the left main or the LAD. If they are both, if it's only the ostium of the circumflex, I always place 2 wires, LAD and circ, predilate, do IVUS to know the size of the vessel. If it's very calcific, consider rota or shockwave, and almost very frequently optimize with cutting balloon, high pressure, size based on IVUS. And if the result on the cutting balloon are bad, go to stent, no way to risk. If the result of the cutting balloon are okay, or you do repeat IVUS and look at the size of the lumen, or you do FFR. If you already have IVUS, you do IVUS, and you find that the IVUS at the ostium of the circumflex is 5.9 square millimeter. That's fine. 6, I go with a drug-coated balloon and leave it like that. So I think IVUS or FFR, but IVUS I think is good enough, and I use the cutoff anything more than 5.5 square millimeter.
Antonio, if you do have to stent the ostium of the circumflex, and you're forced to stent it because you have a suboptimal result, what is your preferred technique?
I prefer the T and minimal protrusion, unless I really have a very funny angle, like 30 degree, where I have to protrude in the left main. Then I do a modified culotte. I stent into the left main towards the circumflex, and then I may not stent the LED. If the LED result is good, I just leave it alone. So if the angle is really very narrow, and I am forced to do a lot of protrusion, then I have to do some kind of culotte.
Okay, a little bit still. We'll just finish with this ostial circumflex. One last question. We'll move on to another topic. There's one of the participants mentions that there is some theory and some data showing that ostial lesions, especially the circumflex, is very fibrotic, and therefore you have a lot of recoil. Do you think that's kind of in your reasoning about why you're using cutting balloons for the ostial circumflex?
Yes, exactly. I use the cutting balloon to minimize the recoil. I needed to create sometimes even some dissection, and I'm not afraid of a dissection. I prefer to place a stent because I cannot get a good result than to accept a mediocre result. Because I know that if I do PCI alone and I have a mediocre result, the long-term result is not going to be good. So I needed to have a good result, and I'm willing to pay the price of 30% crossover to stent, even 40%, in order to get at least in 60% of the cases a good balloon result.
Ahmed?
So moving on to some questions about approach to calcified lesions. What is your approach or algorithm on deciding when you need atherectomy?
Rotablation.
Mm-hmm. Yeah.
If I have difficulties to go with the balloon, I don't like to use 1.5 balloon, except to facilitate to put down the rota wire. If the 2.0 balloon does not go, or even the 3.0, I don't like to start with small balloons. If my regular balloon does not go, I don't use a 1.5. I go with rotational atherectomy. So again, nothing wrong to do some more rotational atherectomies. You have to keep your practice. So number needed to treat for rotational atherectomy has to be 6, 7. You can do 5, 6 rotational atherectomies that are not absolutely needed in order to do 1 or 2 that are really important. So don't be afraid if you did a rotablator, someone told you that you could have done without. It's okay.
Then the second question, with the Shockwave balloon now being more and more available, it's still in trial here in the States, but I know you have it available in Europe. How did that affect your use of rotational atherectomy?
Oh, did not go down. Shockwave is to have optimal result. Rotational atherectomy is to have some kind of result. So you cannot substitute rotablation with Shockwave, but if the artery is big and the 3.0 balloon did not fully inflate, rotablator is too late. It's too small. We don't use 2.0 burr anymore. So you need the Shockwave. The other area where Shockwave should be limited if the calcification is not at least 180 degrees. If it's only focal, 70, 80, 90 degrees, even 100, shockwave is not very effective because you need to have a real nice ring of calcium. So shockwave is important, but do not assume that having shockwave you cut down on aortic ablation. The two are two steps to solve the same problem, but at different levels.
Yeah, Ahmed, you know, after working with Dr. Colombo for many years, there were a few simple rules we had in the cath lab. Okay, and I'm going to repeat them for you here from a slide I have from Colombo. Actually, let me see if I can share this slide. I'm sure you won't mind me.
It's a pleasure to see.
You won't mind me sharing the slide. Hang on a second.
It's good that other people remind me.
So here's the slide. One of the slides I love. You can see my screen, right? Yes. So these are some of the classic rules I learned in Colombo's lab, right? So if you suspect you are subintimal, you are subintimal. I mean, I think that's a very important one. We just saw that yesterday with a case, Ahmed. If you think you need hemodynamic support, you need hemodynamic support and do it, right? And similarly with rotablation, if you think you need rotablation, you need it. Three very simple rules, but I still use those rules today.
Yes, very, very, very important. Just the simple idea that, you know, don't take a chance. I mean, if you think there is the police around the corner, don't speed up, just slow down because maybe there is a police at the corner.
So I saw there was a question here from Richard Jabour, one of your ex-fellows, Dr. Colombo.
Yeah.
What situations would you not stent in STEMI?
When there is a lot of thrombus, really a lot of thrombus, especially the right coronary. Sometimes you see this right coronary. I try to establish TIMI flow, which you can leave the patient on heparin or 2B3As and wait. You really, sometimes goes everything fine, but if you get distal embolization, no reflow, you really destroy a lot of myocardium and you really are not doing a favor to the patient. So just keep the patient 24, 48 hours in the ICU and do so. Big thrombus, that's where I understand.
Ahmed?
I mean, that's a great point. I actually, during this year, I had a couple of patients with the RCA STEMI, and usually those patients, they also have ectatic vessel. It's really dilated and a huge burden of thrombus. And I remember in both situations, we just, you know, did angiojet, we did as much thrombectomy as possible, and we left them on 2B3A, and then Coumadin for like a month. And when we brought them back, it's amazing how good the vessel looks. It really cleans up very well, and both times we didn't have to stent. I wonder if you also had a similar approach with using anticoagulation, you know, like short term or even long term in those patients.
Absolutely, yes. This does not mean the stenting is contraindicated in thrombus. Stenting can be the solution for a thrombus, but in some situations, especially if the thrombus is long and extensive and is acute or subacute, it's better to do what you said. And I have a lot of examples myself and people that showed me how important it is to wait a couple of days, do angiojet or other maneuver and wait.
Yeah. And talking about thrombectomy and you know, all sorts of strategies to treat thrombus, there is a question about the evidence that we have on, you know, especially the most recent evidence on the poor outcome associated with aspirational thrombectomy. What is your comment on that?
I think aspiration thrombectomy should not be used routinely. The aspiration device we have, which is a syringe, is not the top, helps, but sometimes is not ideal. The angiojet, I'm sorry that it's really almost disappeared, except in some centers. But new generation angiojet, especially if you start from distal to proximal, not the old way from proximal to distal, I think is a very good approach for extensive thrombo. So I still believe thrombectomy, especially if you have the right devices, is a good technique and should not be dismissed.
Yeah.
If you are doing like a lot of MIs, 300 years in your lab, I think you should have angiojet. Unfortunately, people don't have it because of economical reasons. But I think angiojet is an important device.
Yeah. And a question about your strategy approaching an occluded artery in the context of late presentation STEMI. When do you decide to proceed to opening the artery, and when do you decide to stop?
Late presentation, I mean, if the patient comes to the cath lab, must be some reason. So I think if I can open the artery, I open the artery, even if it's late, provided I can assume that the artery is supplying a reasonable viable myocardium. If I see the echo that has an aneurysm or something like that, of course, don't do anything. But if, even if it's akinetic, I will still reopen, provided is a reasonable size vessel. Regarding complete or incomplete revascularization, I think the tendency now is to do complete, and not necessarily in the same procedure. You can wait 24, 48 hours, but it's not a bad idea to discharge the patient with complete revascularization.
So, Antonio, there are kind of two slightly philosophical questions that we're going to end with, and then we're going to let you go. I see you in scrubs today, so I assume you're back at work, which I'm glad about. So, yeah, so there were two questions. The one is slightly philosophical. You know, if you look at your experience in interventional cardiology and you look at practice today, are there things that you think of, you know, that maybe us, the younger generation, are doing that we shouldn't be doing, or the direction that interventional cardiology is going that makes you feel uncomfortable and you think it shouldn't be going?
But I think having more restriction on stable coronary syndrome, every time we do an intervention on a stable patient, we really need to get an optimal result. So we need to use IVUS technology to prepare the lesion well, to get an optimal result. With safety, of course, we should not break vessels or stuff like that. But if you use IVUS or CT imaging, so optimal result is very important. And I'm still not a profound lover of super long stents. I think stents are important, but if you can minimize the stent length, I think it's fine. Even if you do not get a shiny angiogram at the end, I think minimize the stent length. Do not use stents like a beauty cream that you put on your wife. Stents are for the critical part of the lesion, and use IVUS, FFR to evaluate what is left over critical and not, and learn sometimes to use drug-coated balloon where, when you have. In America, you don't have it, but sooner or later, I hope you will have to use other devices, or even just balloon angioplasty. I mean, balloon angioplasty works 70% of the time. Not 70% no, 70% yes. So if you do balloon, it's not bad. You always tell the patient that you place a stent. You don't have to tell how long the stent, how many. I place a stent, 2 stents. Even if you don't place 3 stents, it's not a big deal. You place 1 at least. So place 1 stent.
And then the last question is a little bit is about mentoring. What was the role of mentorship or mentors in your own career success? And what is your mentoring philosophy for others that you've mentored?
But try to teach and try to make other people understand what you're trying to teach. If the other person do not understand, means that you are not clear in your mind what you're trying to tell them. So teaching is a way to make your idea more clear, not to the other, but to you. You learn your ideas when you try to teach to someone else. So if the guy, when you teach, looks you funny, what you're telling is not clear, and think that it's not clear to him, it's not clear to you. So teaching is the best way to teach to yourself. The byproduct is that someone else learns.
That's excellent. That's a great place to end, Antonio. Really, I want to thank you for your time. We always love hearing you. It's good seeing you in good spirits, and you look very healthy. And it was nice talking again about cardiology and not infectious diseases. Good, yes, that's excellent. Put your mask back on. Take good care of yourself. And to everybody on the call, we have another lecture on Thursday morning at the same time by Ajay Kirtane, who's going to be talking on an algorithm of how you use hemodynamic support. So we'll see many of you on Thursday.
So we'll be next Tuesday.
No, this Thursday. This Thursday, same time. Yeah.
At 1:30. Okay.
Yeah, we'll send everybody an email to remind you.
I will be there. Okay.
Great.
Ciao. Have a great day. Bye-bye. And thank you.
Thank you, Antonio. Okay. Bye-bye.